Good evening, everyone. It's indeed a pleasure to welcome you all on behalf of Department of Psychiatry, DY Patil School, Navi Mumbai. On behalf of organizing team, I warmly welcome all respected faculty members and participants for today's online lecture. A bit about today's lecture series. The Department of Psychiatry, DY Patil Medical School, Navi Mumbai, has always attempted to pursue academic excellence. In that vein, we started a PG lecture series under the guidance of Dr. Rashmin Cholara for postgraduate students of psychiatry, not only in Mumbai, for all over the students in India here since 2015. We have another dimensions to do it for now. We have now started this format in a video lecture series, and we have also taken the help of the platform of YouTube to further extend it to the knowledge to the other student. This lecture series have helped PGs to learn the newer concepts in psychiatry under the guidance of various experts from all over the globe. We hope this helps PGs and psychiatrists all across the country to enhance their skills and knowledge in the field of psychiatry. On behalf of our department, it's my privilege to introduce our esteemed chairperson, Dr. Ritambara Mehta ma'am, whom we have known for all these years. She has been instrumental as a PG guide, uh, as a faculty in the field of psychiatry. She has headed the department of psychiatry at Government College, Surat, under whose guidance and leadership many young psychiatrists have passed out in this country. Thank you, ma'am, for kindly consenting to chair today's lecture. With this, I request Dr. Ritambara Mehta, ma'am, to take over the proceedings. Over to you, ma'am.
Oh, thank you very much. At the outset, let me thank D.Y. Patil University Medical College and especially Dr. Rashmin Cholera and the team to give me this opportunity to chair and moderate this session. Today, as you all have listened to the chair, that for more than 10 years, DY Patil College is doing, and psychiatry especially is doing this series of lectures, and they have been very well received. And today's topic also is a very interesting, very interesting topic. And we have an internationally renowned speaker, the guest speaker, Dr. Bradley Foote. I really welcome him for this session. Before we start, today's session is actually on the dissociative identity disorder and its overview and update. If I get the slide of Dr. Bradford, I would like to introduce him. He is, of course, a psychiatrist, and he has been a teacher all his life. As you can see on the slide, also from 1989 to 2020, he has been the professor, the associate professor at Montefiore Medical Center, where he also has trained himself and then he has worked there. He is a specialist and an expert in the dissociative identity disorder. Of course, other than that, PTSD and childhood abuse and trauma recovery, because that's where we get a lot of dissociative disorders from. Uh, his research actually spans so many areas, and even the current research is very interesting, which is ketamine assisted therapy, psychedelic assisted therapies, other than DBT, CBT, etc., which we have been using for many years. He has been a researcher and has published more than 15 papers only on dissociation and dissociative identity disorder. As I go through his CV, a very knowledgeable person, sir. We really looking at your CV, I felt that you have been an expert in such a small field. In India, we actually sometimes struggle narrowing down and going in depth because of the mammoth of work. But as you have really dived deeper into this subject, we would really like to listen to you. He has been, I think, the same slide, if I can get the slides have changed. He has been awarded Morton Prince Award for scientific achievements. He has been awarded Irma Bland Award for excellence in teaching experience. He has been a teacher for more than 30 years. He has been teaching DBT, CBT, other than that, hypnotherapy, and so many other brief psychotherapies to the psychiatric residents there. Sir, you have so much of experience, and we would love to listen to you in this session of dissociative identity disorder. And especially, there have been so many changes which we have seen in this particular area as far as the classifications are concerned. In India, also, we see so many possession like syndromes. Whether to call them dissociation or not, that has always been a debate. And now I think things are actually falling in place. A lot of advancements and research in the biological field also, with maybe some biomarkers and other areas, or maybe even AI also, how that can help us in this particular dissociative identity disorder. Sir, we would like to listen to you wholeheartedly. We welcome you, sir.
Thank you very much. I really appreciate that. So thank you, Dr. Mehta. Everyone can hear me, I guess?
Yes,
That's
definitely.
good. Okay, I'll get to my slides in a second. So thank you for having me. I have been doing dissociative disorder things for many, many years, and but I've never spoken in India before, so that's sort of exciting and a new thing for me. So I wanted to thank Dr. Cholera, who's really one who coordinated my coming here, and also not on your list there of staff, I don't think, but Dr. Adathi is a psychologist in Pune, who's a member of the International Society for the Study of Trauma and Dissociation, which is our international organization, and she's the one who really connected me here. So thank you to you as well. Yes, I'd like to talk about dissociative identity disorder. Let me see if I can figure out how to get my slides going here. That I don't think that worked. Are my slides up on the screen now? Yes? You're muted,
Yes,
Dr. Mehta.
yes,
They
sir.
are?
Yes,
Okay.
yes, sir. Yes, sir.
Okay.
Yes, sir. Yes, sir.
Okay, so we're not quite ready to go though.
That down fourth button, sir.
Right. Okay. Okay, so that's my name there. I was at Montefiore Hospital for many, many years, and I have been seeing patients with dissociative disorders for about 30 years or so. And there we go. So today I'd like to tell you a little bit about dissociation in general, then talk a little bit about dissociative amnesia, which is sort of the building block for dissociative identity disorder. I think that helps people understand DID, which we'll call it from now on. Obviously, this is what used to be called multiple personality disorder, and now it's called DID. And then we'll talk mostly about DID itself. And hopefully you'll have a little bit of a conceptual understanding by the time we're done. And I'm hoping to give some practical feedback too that might help you either recognize it diagnostically, or if you get a case of DID, to have some feeling about how you might proceed with it. I usually, at this point, when I'm giving a live lecture, I ask for a show of hands. How many people have ever seen a patient with dissociative identity disorder? I don't think I can do that right here. So I'm presuming that some of you have, and that some of you may have seen patients that people said they had DID, but you weren't so sure. Anyway, so I'll try to help you sort some of that out. The first, and I'll say one more thing. I've given a lecture on DID many, many times. It doesn't fit into the 45 minutes here, so I'm going to be definitely skipping some slides as we go along. And I also wanted to say that, in America, we use the DSM diagnostic system. Preparing here, I had to go through compare the ICD-11 with the DSM, and there's there certainly are some significant differences, especially with functional neurological disorders, which are in the dissociative disorder in the ICD and which are not in the DSM. But the definitions for dissociative identity disorder itself and for dissociative amnesia itself are pretty much identical across those two different systems. So I just stayed with my DSM slides rather than making new ICD-11 slides because I think that they are, for this purpose, they serve fine. So the essential feature in the dissociative disorders is disruption in the usually integrated functions of consciousness, memory, identity, or perception of the environment. And I'll take a minute to break that down. When you and I get up in the morning, if we don't have a dissociative disorder, we expect when we get out of bed to feel like we're the same person that went to bed last night. We expect to look at ourselves in the mirror and it looks like us. We expect to feel connected to our own body. Like if I use my hand to brush my teeth, my hand works fine. It feels like it's my hand. And then as I go through my day, I expect to feel like I'm the same person all day. And then when I get to lunchtime, if somebody asked me, what did I do today? I would be able to tell, well, I did this. I would have continuous autobiographical memory, right? That is the usually integrated function of consciousness, memory, identity, and perception of the environment. So it's disruptions in that define the dissociative disorders. So you had a disruption in perception of the environment. That would be usually derealization. If you had disruption in your feeling of connectedness with your own body or with your own self, that would be depersonalization disorder. If you had gaps in autobiographical memory, that would be dissociative amnesia. And if you had both gaps in memory and a discontinuity in your sense of self, like feeling like you are different selves at different times with gaps in memory, that would be dissociative identity disorder. So those are dissociation is those kind of disconnections. So one of the things that I'm not going to have time for is to do history. Dissociative identity disorder was known there were case studies from the 1800s. The studies in hysteria, if you look at those cases, a lot of them seem at this point like they have dissociative disorders. But the disorders were kind of neglected for a long time. That changed in the 1960s, 1970s. And this slide is just showing that one of the reasons that changed is because society in general became much more aware of the prevalence of sexual abuse. And sexual abuse, as we will see, is very connected with dissociative identity disorder. And so these are some textbook estimates of the rarity of incest, like one in a million people, right? But so this would be prior to 1970, 1980, this would have been the prevailing view. We, of course, know that childhood sexual abuse is much more common than that. And those are the, current statistics down below. And that was a sort of let me go back there, a societal change that feminism and sort of more attention to things that were happening to women. A big thing in our country was mandatory child abuse reporting, which started in the 1960s. And so there just became more societal awareness and interest in the fact that bad things were being done to children, to female children. And along with that sort of opens the door to being able to see some of the disorders that come along with that. And DID is like the main one. Okay, so back to the concept of dissociation. I just want to talk about that. for a minute. So there's a continuum of normal dissociation to pathological dissociation. I sent along to Dr. Cholera the DES, the Dissociative Experiences Scale. I'm not sure how they are able to distribute it, but if they aren't, you could just go online and print this out very easily. Dissociative Experiences Scale. This is the main measure that's been used for many, many years to measure dissociation. It's not a diagnostic instrument. It measures dissociation in general. And so this first item here, some people have the experience of driving or riding in a car or subway, suddenly realize they don't remember what has happened during all or part of the trip. Right. So if I could see you raise your hands, I'd say, how many people have had that experience? And most people would raise their hands, right? So this would be, that would be considered dissociation, right? You went through the whole trip and you don't even remember seeing things, right? Because you were focused on one thing and didn't need to focus on other things. Or you're so absorbed in reading a book that you don't even know what's going on, right? Those would be normal dissociation. The second item here, some people have the experience of finding themselves in a place and having no idea how they got there. People who don't have a dissociative disorder do not endorse that. That's not something that happens to people that don't have a dissociative disorder. So that would be considered to be pathological dissociation, right? So this is the idea is that dissociation is something that is distributed in the general population. Some people are more dissociative than others. It is a heritable trait, and we'll talk somewhat about the genetics of dissociative identity disorder later. But that sort of basic ability to dissociate, which is a biological capacity that human beings have, is just sort of is in us to greater or lesser degree. What has become clear over time is the association between dissociation and trauma. And there's tons of different streams of evidence that make that connection. If you look at adults and take the ones that have high dissociation, they have much more trauma history. If you look at people with trauma histories and follow them, they have much more dissociation. You can measure if you see an earthquake or some natural disaster, they can measure how far you were from the epicenter of that thing, and the dissociation scores will be highest near it and lower as you go out from it. A well-known study in the 70s of people with no psychiatric history that were in a extremely frightening automobile accident, not injured, but frightening. Some 60% of them had some amount of either memory distortion or depersonalization or time distortion during that. So it's clear that dissociation is often and to a good extent associated with trauma, and that will be important as we go along here. Okay, so the building block of DID is dissociative amnesia. So that's the very specific symptom, an inability to recall important autobiographical information, usually of a traumatic or stressful nature, which is inconsistent with ordinary forgetting. And that can be its own freestanding diagnosis, and we'll talk about that in a minute. But it is always part of dissociative identity disorder. It's sort of the essential feature. And the classic dissociative amnesia case was studied during the world wars. There's a whole literature on the things that soldiers suffered. And the classic is a soldier who's in his normal state of mental health, and then a horrible battle erupts and people are being killed all around him and he's terrified. And the next day he's found physically uninjured, but having no memory of what happened. And that might include having no memory for who he is, or it might just be very focal, he remembers everything fine right up until the stuff started, the battle started. And the treatment for that, classically, would be to evacuate the soldier and in World War II, they would have given them sodium amytal, or they could use hypnosis or just being in a sort of safe, supportive environment. And the idea is that you're going to help the person recall the traumatic material, and that it's going to come back. They're going to have all the emotions, and they're going to cry, and they're going to scream and be angry, and all the feelings that went with it. And then after they've reintegrated that memory, and have the access to the memory again, and have dealt with all the feelings that made them block it out to start with, they're essentially recovered. So that's sort of the pure culture acute dissociative amnesia, and which illustrates the two really key points about dissociative amnesia as opposed to other amnesias. One is the association with trauma, typically, and the other is that it's a potentially reversible amnesia, right? So these are people who went through an experience, were not able to recall it, and then after treatment were able to recall it, right? So the memory was stored, but it was not able to be accessed. And that concept is very important in DID, because that's what DID is all about, is all these traumatic experiences that were stored, but that are being blocked from access. So this is, I'm not going to go too much about, so this is distinguishing dissociative amnesia from organic amnesia, and the differential diagnosis of dissociative amnesia, which the first two, if someone tells you, yes, I have periods of time that I can't account for, this is one of the main questions you will be asking if you're trying to diagnose a dissociative disorder. Do you have periods of time that you can't account for? Or do people tell you that you've done things that you don't remember, right? So these are gaps in autobiographical memory. What are the other things that would occur to us as reasons why people would have gaps in autobiographical memory? Seizure disorder, right? That would be one. And intoxication would be the most common ones, right? So why do people, if the history is, yes, I went to the bar and had a few drinks, and that after that, I don't remember anything until I got home. I guess my friends must have brought me home, right? That doesn't sound like a dissociative disorder. That sounds like a intoxication, right? So anyway, those are the other main organic causes. But in those, and again, to make this distinction, if someone has an alcoholic blackout, for instance, they're never going to be able to recall those memories. Those memories were not stored normally. That's what makes dissociative amnesia different. In dissociative amnesia, the memories are stored as they normally would be, but they are somehow blocked from awareness, or one is unable to access them. So the memory is there, but it cannot be accessed. It is dissociated. Okay. So that's sort of the key building block of dissociative identity disorder. Okay, dissociative identity disorder. I think everyone has a sense of what that is, right? It's just such a dramatic thing. You've seen it on TV and stuff like that, but it's disruption of identity characterized by two or more distinct personality states. And as Dr. Mehta said before, here it says, which may be described in some cultures as experience of possession. In the United States, possession is not a widespread phenomenon. I know that a much more common kind of thing in India. So I think that differential diagnosis, possession trance or possession state versus DID, is an interesting and complicated one, and one that I don't have much personal experience with here. If we end up having time at the end, we could try to talk about that a little bit. So you've got two or more distinct personality states and memory gaps that go along with them. Okay, it's basically dissociative amnesia is a monosymptomatic condition. You have this one symptom, you have dissociative amnesia. Here we have two symptoms. You have the different personality states and some memory disturbance that goes along with the switches between personality states. So that is the extent of the diagnostic criteria for DID. So I'm going to very, very quickly try to paint a picture of how someone comes to have DID. Um, and so, so first of all, DID is a disorder that develops in childhood, period. If you expose an adult to severe trauma, they probably will get PTSD and they may have various other symptoms, but as far as we know, they will not develop DID. That it only develops when one is exposed to extensive repeated trauma during childhood. Um, and again, if we have time, we can talk more about why that would be, but that empirically is true. There's a window of possibility to develop DID, and it's unclear exactly when that window shuts, maybe age 12 or something like that. But after that, if you have trauma, you're not going to get DID from that trauma. So if a patient comes to you and says that they think they have DID, and the only trauma history they have is something that happened to them at age 25, either they don't actually have DID, or there actually is other childhood trauma that they don't remember. So those are the two possibilities. We don't think it's really possible that someone that did not have a traumatic childhood and has an adult trauma can develop DID. So in this picture I'm painting, you have a child, let's say a 4-year-old, and she's in bed at night, and her stepfather comes into her bedroom and rapes her. Okay, so that's the index traumatic event. We've already seen from what we talked about before, from the studies from the 1970s, for instance, that people that are confronted with a sudden shocking trauma, like an automobile accident or certainly a sexual assault, can have spontaneous dissociation. A very common one is depersonalizing, feeling like I left my body and I was just watching what was happening. Also common are time distortion and memory disturbance. Now, this person commits this assault. He says to the girl, "Don't tell anyone this happened, or I'll kill your mother." Or he makes some threat, some very effective threat. So the person is, not going to say anything. So she's now carrying this in her mind and not able to do anything about it. And then at breakfast the next day, her mother and the stepfather are sitting at the table together. So she's in a very difficult psychological position, right, of being aware of this horrible thing, which doesn't help her to be aware of. So you can see there would be a sort of an inherent motivation that if she could sort of have that memory be a little bit more distant or sort of put it out of her mind, that would be sort of psychologically adaptive, right? And so DID doesn't develop from one trauma either. It develops from repeated trauma. So the picture I'm painting here is this trauma happens repeatedly, and what happens over time is that the girl starts to have sort of two different states of mind. And again, remembering dissociative amnesia, these are memories that are stored, but might not be accessible, right? You're not aware that they're there unless the proper conditions come about for you to remember them. So it is psychologically adaptive for her to block off the memories. However, the memories are there, and in fact, she's going through the experiences, so she has to still be aware of it and go through it and interact with this person and stuff. So what we believe develops over time is that she sort of can be in one of two states. One state, which is a girl who does not remember these things, and the other is, which she's in, switches into a different personality state. She's the one who's undergoing these things and remembering them and aware of them. And so she starts to develop sort of two parallel tracks. She can be in that state of mind or in that state of mind. And there's a phrase called structural dissociation that refers to DID. In other words, it starts to become not just a traumatic event, but sort of part of the person's psychological structure ongoingly, that there's different states of mind that they can be in, some of which have access to traumatic memories and some of which don't. And you can see how that would be psychologically adaptive to do that. And so when that starts to develop prominently in a child, dissociation starts to then be used to deal with other difficult issues. Like, for instance, the child may be feeling very angry about what's happening, but it would not be safe to express or even to let herself know the anger. So maybe the anger gets sort of separated into another state. So she can, at times, if she's in that state, be very angry or be aware of anger. But most of the time, in her regular state of mind, she's not aware that she feels angry. Right? So now maybe you have a situation where you sort of have, so anger is sort of located in one part of her personality that she can at times go into, but usually doesn't. The traumatic memories are located somewhere else. And then the sort of the girl who goes to school every day and acts like everything's normal is somewhere else. And that over the years, that sort of starts to build, and the person starts to use dissociation more and more, ultimately resulting in a structure where there's the person's personalities split into different aspects which sort of perform different functions and do not have access to the same memories. Okay, I usually do a longer version of that, but I'm trying to sort of paint a basic picture of how we think DID develops, and we can come back to that later if anyone wants to. And that person ends up in adulthood still with these splits in awareness and still with either no awareness of the trauma history or limited awareness or only intermittent awareness. Like they may get flashbacks or horrible intrusive memories, but then they block them out and then they're back to being unaware of them again. Okay. So a few just little factual numbers about dissociative identity disorder. The one I didn't put on here is that the prevalence typically is found to be about 1% in general populations, which is comparable to the prevalence of schizophrenia. And at first, there was a thought that was an inflated and high number, and that was only in certain like developed countries where DID was in the media a lot and stuff like that. But this has now been replicated in many countries around the world. So we do think that that's generally a ballpark number in the general population. And if you go into outpatient psychiatric populations, it's higher. If you go into inpatient psychiatric populations, it's higher. So it's bottom line being, it's not a rare disorder. We think of it as a rare disorder, but it's actually not so rare, which is surprising, but true. It is mostly a disorder of women, and we think that's for a couple reasons. One is because these patients usually have some pretty serious disturbance, including a lot of intense anger and stuff like that. And males who have those kind of symptoms probably end up in jail, not in the mental health system, whereas women might be more likely to not get arrested because they're violent and they would end up in the mental health system. But also, replicated many, many times around the world is that physical abuse of male and female children is about roughly equal, but sexual abuse of female children is much greater. So since that's the number one risk factor for DID, you can understand why there's more females than males with DID. As I said, age of onset, childhood, but it's rarely diagnosed in childhood. And I want you to look at the little thing at the bottom there. At the time of diagnosis, the patient has spent an average of 7 years in the mental health system with an average of 3 prior inpatient hospitalizations. Point being that this DID is hard to diagnose. It is often not diagnosed. People aren't necessarily educated about diagnosing it, and also the patients are often really not able to articulate their symptoms clearly, present in sort of confusing way, and rarely show up saying, I have symptoms of DID. It's usually something that you have to really sort of figure out over time with people. It's not easy to diagnose. So if you think of the fact that people are in the mental health system for years and getting hospitalized and in and out of the hospital, and nobody's making the diagnosis, well, what are the diagnoses that these people are being given? Well, so this would be the differential diagnosis of DID, but it also is the list of incorrect diagnoses that people with DID are sometimes given, that sometimes have DID. And the first two I want to go through because they're important to understand. People with DID, and we're gonna talk about the phenomenology of adult DID in a minute. But again, I'm relying on the fact that you guys probably all have a little bit of an idea in your head of what DID is supposed to look like, with very different personality states that act differently. So you can see why that people would give them a diagnosis of bipolar disorder. Someone who seems normally sort of very meek and mild and depressed, and then suddenly they're out partying and being promiscuous and drinking and very sort of aggressive and confident. And one certainly that would be a diagnosis that would come to mind. Oh, maybe they're now in a manic episode. That was a depressed episode. This is a manic episode. The way to distinguish that would be a couple ways. One is that people in manic episodes still feel like they're the same person, whereas in DID, the person that's out partying might have a different name or feel like they have a different age or they look different or whatever. So which wouldn't be part of bipolar disorder. And also bipolar disorder, you would normally still have memory from one state to the other, whereas in DID, you probably wouldn't. And the other thing is that even rapid cycling bipolar disorder, you do not go from depressed to manic in 1 second. It takes, hours or days. A switch in dissociative identity disorder is basically an instantaneous thing. The person is here and they switch to a different personality state. And if you've seen it in your office, maybe it takes 5 seconds or maybe it takes 1 second, but it doesn't take a day. And so again, if that switch is pretty much instantaneous, that's not bipolar disorder, and that would be consistent with dissociative identity disorder. Schizophrenia would be a common misdiagnosis and sometimes a difficult differential diagnosis because most people with DID experienced their other personality states as hearing them talk to them. Not all, but it's very, very common part of DID is that the person is getting auditory input from other personality states. So they are hearing voices. And again, that really can be a tricky differential diagnosis, and sometimes you have to get to know the patient well. I remember this patient that was presented to me in a team meeting one day, a new patient, the diagnosis of schizophrenia, and when I talked to the patient and about this voice she was hearing, she said, "Oh yeah, that's Angel. Yeah, I don't want to let her come out because when she comes out, if she cooks, there's will be eggshells in the batter and everything. She makes a mess." So that starts to sound like not like your typical voice of schizophrenia, right? So again, they can be difficult to distinguish, but in DID, the voice is personified, and also there's usually a lack of other psychotic features. Okay, I'm not going to go through the rest of the differential diagnosis here. Actually, I'll just say the last thing I did, which I just put on for this presentation because it's recent, is inspired by social media. I presume that that's true in your country as well. There's sort of a new thing in recent years of especially teenagers going online and sort of talking about their DID and sort of making a dramatic thing of it. And so that I think has complicated things sometimes for us clinicians as to whether if someone comes and says, "Oh yeah, I think I have DID," is there been some kind of social media contagion there? So that's sort of a new tricky phenomenon. Okay, so this is a list of the symptoms that you'll use to assess these people, and also is a list of symptoms to understand what the disorder is like. Um, the main ones, again, if you were only going to ask one question to try to probe for dissociative disorders, it would be, do you have periods of time that you can't account for? Memory gaps. Missing time is a way that people, and another way to ask that is, do people tell you about things you've done that you don't remember, or conversations you've had that you don't remember? Disremembered possessions is a funny one. People will say, yeah, in my closet at home, I've got my regular closet, and then right at the end of the closet, there's all these crazy, sexy outfits that I would never wear. I don't know why they're there in my closet, but they are. Or yeah, in the bottom drawer, there's all these crayons and coloring books and stuff like that. I don't have any kids. I don't know why they're there, but so those are little clues that there's maybe other personality states that are out sometimes. Or the person says, yeah, when I go grocery shopping, I get to the checkout line and there's all this stuff like, kid stuff in the basket that I didn't put in there. I don't know where that came from. And so anyway, those are so discontinuities of experience, and then clues of that there's other personality states that are active in some way. Changes in handwriting or disremembered writings. It's an interesting thing if you ask patients if they keep a journal. If they do, not infrequently they say, yeah, there's sometimes there's entries in there that look like they're totally different handwriting, and I don't remember writing them. That would be another way that this might manifest. Intrusive mental images and flashbacks are part of the PTSD, which is also always part of DID. Okay. These personality states or self states are also in the classical literature known as alters. A typical structure would be the patient who comes to see you is sort of polite and depressed, quiet, but that the other parts that you may come to know over time, typically there's angry ones, destructive, hostile ones. Suicide is a big problem. We'll have another slide about that in a minute. Impulsive, party states, and often these are teenage parts. It's often hypersexuality. Almost always at least one, if not more, child states. And then you have parts that are functional, that are really defined by, yes, that's the one that goes to work. That's the one that takes care of the kids. That's the one that has sex with the husband. Commonly, not always, you have at least some alters of the opposite gender. This is some research that I did, but it just confirmed research that had been done in the past. The very high amount of suicide attempts that are in the history of these patients, they're very suicidal. And in my study, which I have a much bigger study that I haven't published yet, I'm trying to work on getting published, replicating this study with almost identical findings. So over 70% of these people have suicide attempts histories, and most of them have multiple attempts. They're really chronically suicidal, these people. And if you think of it, it's because they had horrible childhoods, and from those childhoods, they took terrible messages about themselves, blaming themselves for sexual abuse, and about the world, that the world is an unsafe, horrible place, and I'll never be happy. These people have typically been suicidal since they were 8 years old and realized, oh, I can't escape from this hell any other way, but at least I can kill myself if I need to. So if you end up wanting to treat these people, if you like treating people with borderline personality disorder, which I do, but a lot of people don't, I often say that patients with DID is sort of like a severe borderline combined with someone with severe PTSD. Those sort of that combination together is what these patients are like. I'm looking at the time, which is already just about when I was supposed to be wrapping up. So I'm going to do this very quickly. How do people come to have DID? There is a biological component. We call that dissociativity. I have another slide with twin studies that show that there's a significant heritable aspect to being dissociative, as measured by the DAS. Impaired attachment, no time to talk about that. And then severe sustained childhood trauma. And the last note is found in the setting of complex PTSD. You guys have complex PTSD in the ICD. We didn't get it into the DSM yet, but all of us in the trauma field believe in complex PTSD, which is the special version of PTSD from prolonged, inescapable trauma. And that's what these people have been through. I'm not going to get to really go through fear circuitry stuff, but this is just a worthwhile thing. And maybe you guys are pretty aware of this, but in this is research from the 2010 era, that was really important. That it ended up with a dissociative subtype of PTSD ending up in the DSM, but also really gives us some validation for the whole dissociation construct, that if you take patients with PTSD and take a relevant trauma script for them and put them in a fMRI machine, most people exposed to that script show increased heart rate and activation in the limbic system, and the regulatory regions like the prefrontal cortex and the cingulate cortex are reduced. So they're activated in a highly aroused state. But 30% exposed to the trauma scripts don't have the autonomic arousal, have depersonalizations or derealization, and have the opposite activation pattern in the brain. So in other words, there's a response to trauma of activation, and there's a response to trauma of dissociation. And that's been really nicely shown in a laboratory setting. Okay, this is the genetics thing, which I'm going to run through. And all the physical studies are always tough to differentiate PTSD from DID. I'm going quickly here. So again, many times looked at, these patients, almost all of them have extensive physical and sexual abuse. This is a whole thing about complex PTSD, which I'm going to have to skip, just that there's single trauma and there's chronic trauma, and the chronic trauma leads to complex PTSD, which is in the ICD, as I said. Okay, rushing through here, and we'll try to finish in about 2 minutes. Basic principles of DID treatment. It's a psychotherapy treatment. They, just like people with borderline personality disorder, end up on a lot of medications because they're so symptomatic, but the medications don't really cure the borderline. Similarly here, if they're going to get better, it's going to be through psychotherapy. And that psychotherapy has a number of components typically. The main thing from the start and all the way through to the end is to start to make contact with the different parts of the person and bring them into treatment. So for instance, if there's a part of the patient that's suicidal, but doesn't want to talk to you as a therapist, and you don't end up being able to talk to them, you're never going to access that suicidality in the treatment. So it's going to be sort of untouched by the treatment. So you're always trying to relate to and interact with the parts and help the parts work on cooperating better. I'm not going to do this slide. This is just to say, Judith Herman's classic book, Trauma and Recovery, still sort of a Bible in the field, just that it's a staged treatment. And the first stage being establishing safety before you go into trauma work. So here's some tips. Don't rush to diagnostic judgment. It sometimes takes a while. If you do really figure out that a patient has DID, if you do nothing else other than just say I know there's you have different parts of you, and I want all parts to know that they're welcome to communicate and to give input and I'm interested in hearing from them and what their perspectives are. You've already done a really good thing by doing that. Um, do not rush to elicit detailed trauma history. You're not doing the patient a favor if you get them to tell you an intense trauma story right early in treatment and they feel overwhelmed and flooded by that and then go out and cut themselves. You need to establish safety first before you get into trauma work. The transferences are very complicated, especially if you're a male therapist, as most of the perpetrators have been male, but most of these patients have had both parents be terrible. So they usually have all kinds of mistrust and other kinds of negative expectations as they enter the treatment relationship. Go slow. It's a slow treatment, and seek supervision. And I mentioned at the start of the lecture, Dr. Adathi from Pune, who I don't have her contact information to share here, but I'm sure that through Dr. Cholara, you can get to her. She's an Indian expert on DID. I'm sure she'd be happy to try to hook you up. She's not the only one, luckily, at this point. These are some other slides that I'm not going to bother with. Okay. That's my little talk on DID. And I'm happy to hear thoughts, reactions, questions.
That was uh, very excellent, sir. There are some questions which I'll put you through. Uh, uh, a person is asking are these if BID patients have any they get seizures?
If
That
DID
is
patients have seizures,
convulsions.
there is right. I all the way at the end, I have a slide about conversion disorder, which or functional neurological disorder, which you guys have in the dissociative disorders. Classically, there is a heavy association between psychological dissociation, which is what I've been talking about, and somatoform dissociation, which is otherwise known as conversion disorder, which can manifest in all kinds of different ways, functional neurological symptoms, right? And what they used to call pseudo seizures, and now they call non-epileptic seizures, right? Very common. There's sort of right. So these patients, luckily, not all of them have a lot of conversion symptoms, but it's really common, and it's another complicating thing in the treatment. So yes, that's often a comorbid condition.
Okay. One is asking, is there a role of lorazepam assisted interview to hasten the process of eliciting trauma related history?
Great question. I think that our field, the dissociative disorders field, was guilty of some mistakes early on, and I think the main mistakes that we made often were sort of along those lines. In other words, yes, it is possible to put the patient in an altered state where you can access their traumatic memories, and that classically would have been done with hypnosis. But people would be hypnotized to remember their trauma, right? Lorazepam, the goal would be the same, right? We typically don't think that's a good idea because essentially, if the person is not ready to remember their trauma in their normal state of mind, for us to sort of somehow go in and forcefully pull it out of them and show it to them is not thought to be a therapeutic thing to do. So while you certainly might be able to access traumatic memories that the patient is having a hard time accessing, it usually wouldn't be thought of as a therapeutic thing to do. I can imagine an unusual circumstance where there might be some reason why you would want to do that, but in general, it wouldn't be a part of treatment.
Okay, right. Uh, there are some more questions, sir. One is asking, what can be the neurobiological correlates for the switch? Like a person suddenly takes on this dissociation or identity. So, what
Right. Well,
can be the
right. So
neurological?
sure. So that was one of the slides I ran through very quickly. One line, one of the slides was that um, in terms of brain studies, um, that some very nice studies in recent years that have been able to distinguish on fMRI between um, people with DID versus people simulating DID, and also um, in a given patient who has, let's say, one personality state which is uh, kind of calm and doesn't remember the trauma, and another one which is very emotionally aroused, that you can distinguish between them also on fMRI. Um, you um, and I don't have a way to convey I have the references right here. I don't have a way to convey them to you right in 1 second, but if you wanted to ask me for them later, it's so anyway, there's some nice objective fMRI stuff documenting that you can see the difference between different states. Um, I hope that answers your question.
Okay. Okay. One is asking, sir, that if a person with DID is treated with antipsychotics or antidepressants for a long, long time, maybe misdiagnosis, then what happens? Some side effects, and what can be the outcome?
Sure. Um, well, treating someone with antidepressants these days is usually not that harmful, right? Because I mean, SSRIs are not very toxic, so probably with antidepressants, probably no great harm done. Um, the depression that comes from extensive childhood trauma doesn't usually respond to antidepressants, so you won't accomplish much, but you probably won't harm the patient too much. Antipsychotics obviously are much more toxic medications. And in my field, it's certainly one of the things we really try to avoid is that particular misdiagnosis as being psychotic and then being placed on antipsychotic medications. There actually are occasional role for antipsychotic medications in DID, just sort of slow down sort of acute crises where sometimes people are switching so rapidly that it's almost like it's overwhelming and good. And so sometimes antipsychotics can just sort of like clamp down on things and slow things down as a very temporary measure. But the voices of DID will not respond to antipsychotics. And sometimes I say, if you have a patient and you're not sure if they have a psychotic disorder, if those are psychotic voices or DID voices, and you want to do a trial of antipsychotics, that might give you useful information. If they go away pretty dramatically with antipsychotics, then you think, well, maybe that patient did have a psychotic disorder. If it has no impact, that would be a piece of, you know, information suggesting that perhaps it's not a psychotic disorder. But yeah, we obviously really try to, and that's certainly one of the things I end up doing is taking patients off antipsychotics that were put on them, and I would rather not have people on antipsychotics if it's not doing them any good.
Right. Right. Sir, some of us would definitely like to know more about the psychedelic assisted psychotherapies that you have, and people are asking questions. Yes.
Yeah, that's obviously a hot topic and very interesting. It's a recent thing I've been doing for the last 5 or 6 years, and it's really interesting. It's not particularly relevant to this lecture, though. That would be a
But
whole
still,
different
your
lecture.
experience, sir, if you can share some.
Oh, okay. I think that I have some. I was in one of the study therapists on the trial for MDMA and PTSD. I think that the two areas where um, psychedelics they're not legal in the United States yet. So those of us who want to do that kind of work, exploratory work with psychedelics, what we the only one that we can use is ketamine, which is maybe not quite as good as a psychedelic, but it's legal. So, but in research settings, psilocybin has been shown to be very helpful with depression. Psilocybin has been shown to be very helpful with late life anxiety. In other words, people with terminal illnesses, sort of dealing with end of life issues and anxiety about death. Psilocybin has been very helpful for that. And MDMA has been very helpful in PTSD. Uh, it's and the way in which it seems to work. And I think that MDMA would be great for DID. It's just that these DID patients are so complicated. You have to really get to know the patient well first and get to know their parts first before you would want to put them on a psychedelic experience, because they're so suicidal and it's so tricky. You wouldn't want to just have somebody walk into your office and say, "Oh, this is going to be good for your DID." It wouldn't be. But the things that MDMA are known for, which could be very helpful in DID and which are helpful in PTSD, one is that it sort of makes people feel sort of warm and compassionate and connected. So that could help with the therapeutic relationship, but especially with the relationship between different parts. Usually, one of the big things you're doing in therapy with DID is the parts are at war with each other, the different alter states, and you're trying to be the mediator that gets them to all realize that they're stuck with each other, they're in the same body, and they have to figure out a way to cooperate and get along and communicate, and that's going to make their lives better. So MDMA could be helpful for that. And the reason it helps for PTSD, we think, is because when people are in that state of being on MDMA, it's sort of a very calm, open kind of state. And it seems to allow them to revisit their traumatic past in a much calmer state. I mean, we all know that the main thing that maintains PTSD is avoidance, right? It's the trying to block out the flashbacks and the feelings and avoid the triggers, um, and that the clearly very effective treatment for PTSD is exposure therapy of various sorts, right? That can take a number of different forms. Um, with MDMA, the people ideally are able to sort of go back and really look at that traumatic experience and not have to, and just sort of see it more and perhaps be more forgiving to themselves about it, sort of re-examine the experience from a more compassionate place and from a less avoidant place.
Okay. And sir, if you can share your experiences with the outcome, like do they come out of this dissociation completely? How many
Oh, with
percentages?
DID.
What
So
would be the prognosis for
sure,
any some
absolutely.
tips there?
Yep. I that was maybe on one of those slides, I'm not sure. DID is very rewarding to treat because these patients do get better. I mean, like schizophrenia, obviously the person is not going to lose their schizophrenia. You're just trying to control the illness. Here, the treatments are long and difficult. You have to deal with a lot of suicidality and anger and other things. But the patients do get better. It takes a long time. And there's a whole range. There's patients that are so sick and have so little ego strength to go along with you have much more limited goals. But a lot of these patients, can be high functioning. They could be doctors, lawyers, professionals, parents, people who are functioning well in life, but they just have this whole inner turmoil and torture. And so they can be very high functioning patients, and you can really help them. It's a
Okay.
pleasure to treat these people.
And okay, question is how prevalent is personality disorders in this population? And
Great
sometimes
question.
the persons with personality disorder also say that I don't know why I acted this way or that way. So and things are uncontrollable. So is that dissociation or not?
Well, great question. Uh, High comorbidity, especially with borderline personality disorder. A number of series, including a couple of mine, show in a DID population, probably anywhere between 50 and 80% of them have meet the criteria for borderline personality disorder. Um, And the reason for that is because, as we also are starting to know better with borderline often also comes from a traumatic childhood. So, right. So if you have a very emotionally negative childhood with trauma in it, DID is something that can happen. PTSD is something that can happen, and personality disorders are something that can happen, and they can all happen together at the same time. So yes, they often run together. They often look similar, and they often sort of come from the same place. And the so a patient with a personality disorder that it obviously, yes, could be impulsive and in the grips of different affects and do something, impulsive, hurt themselves or get angry, smash things up. Um, the difference would be theoretically that person, though they might say that they couldn't control themselves, but it wouldn't feel like it was actually a different person, and they probably would still have continuous memory for the experience, as opposed to if it was an alter that had taken over, that might actually feel like a different person, and they might have no memory for it. I mean, and these patients will show up in an emergency room all cut up, and they're like, I don't know how that happened.
Okay. Yeah, okay, sir. And Shalini is asking, she is a trauma-informed therapist. I think she can talk if she puts, she can unmute herself, but I'll read it out. She says that many find it difficult to use it as there are probably not enough RCTs, randomized control trials on trauma-informed therapy behind effective in DID. Can you guide for that, sir?
Sure. Yes, and then I guess we probably should be wrapping up soon, I think here.
Yes.
Uh, Randomized controlled trials for treatment of DID, that's so difficult to pull off. I mean, so expensive, and these are long-term treatments. We have to have specialized therapists. So there aren't any just flat out like a randomized controlled trial for someone or a cohort of DID patients getting standard DID treatment, which I could talk about what that is, or how to access that, but versus not getting any treatment or versus getting, I don't know, just regular psychotherapy or something. But what we do have now, which is great, a woman named Bethany Brand has done a couple of big RCTs and published them with essentially a set of, it's a little bit DBT like, it's sort of a whole set of skills that is added adjunctively to an ongoing treatment. So she has groups of patients. So all these patients were recruited. They all have DID. They're all in outpatient therapy with a DID informed therapist. Half of them get this additional group treatment once a week for 30 weeks with a bunch of DID skills and demonstrating very impressive results. So that is the closest thing we have to an RCT, but it's a very nice one. But actual total RCTs of individual therapy versus not, that does not exist. And my guess it probably never will exist.
Yeah, difficult. Yes, sir. Some people are asking for the references that you have talked about, sir, and some resources from the International Society for the Study of Trauma and Dissociation.
Okay.
Maybe if you
Well,
can share with Dr. Cholera, he can share with the group. Question or two. We use
I would be happy to
EMDR for these kind of.
let me
Yes.
just say one thing. I of course, will be happy
Okay.
to share references with Dr. Cholera later. You just mentioned, and I'll re-mention it, the International Society for the Study of Trauma and Dissociation, ISSTD. That's sort of the international organization that we're all part of. And they have every 10 years or so, they redo treatment guidelines. It's a very long document, like 150 pages, but it's very thorough. So is a great starting place. If you had a patient like this, again, find a supervisor. But the ISSTD treatment guidelines are a great starting place, and they have other resources and stuff too. So yes, I'm glad you mentioned that, and that would be one reference I'll just put out. I'll try to share it again later also, but
Okay, so all the resources are on the website, sir, of this ISSTD. Are they on the
there
website available freely?
are all these references on the website?
The you said guidelines.
The guidelines, yes, you can access them on the website. Yes.
Okay, great, sir. Maybe a few more questions, sir, if you can answer.
I'll tell. How
We
about let's say two more questions.
okay, yes. EMDR, is it useful as we use in PTSD? Is it used in DID?
By the way, I'm totally impressed with these questions. Every single question is very on point here. So number one, you guys were definitely paying attention, and number two, seemed like a very trauma-informed group here. It's lovely to speak to you. So EMDR is used with DID. However, it can be tricky. And actually, I know that ISSTD, that I was just talking about, offers every year a whole specialized training for EMDR with DID. And I have seen, and everybody in my field has seen, that if somebody who doesn't really know anything about DID and they start doing EMDR with a patient who has, for PTSD, and they're not aware of the DID, the patient end up switching or can have very destabilizing or frightening experiences for the therapist and for the patient with EMDR. So it can be used and is used, but it ideally with a little bit of specialized training in the use of EMDR for DID.
Okay. I think we have reached the end of the question, sir. It was
Perfect.
really, really lovely and very, very informative and very resourceful, sir.
Thank you,
Thank you
Dr.
very
Mehta,
much.
and
And Dr.
thank you, all
Cholera,
of you.
if you want to add something, and the other chair.
Hi. Uh, Thank you.
You're welcome.
Uh,
My pleasure.
it was an absolutely brilliant talk, and I'm not surprised at all with the amount of enthusiasm you have managed to garner through your session. It is an interesting topic. Most of us haven't been adequately exposed to it during our training years, though dissociative disorders are culturally extremely common in India. So it is not surprising at all that we have such a lot of interest from the audience and the postgraduate students. And I suspect there are a whole bunch of psychologists as well on the forum today. So they are also participating quite enthusiastically and rightfully so. They are always a part of our treatment team and they help us a lot in dealing with these cases. But absolutely brilliant, Dr. Foote. And we are really grateful that you could take the time to be with us today, all the way from halfway across the globe. And we hope to have you back on this forum for similar such talks. And I hope you would grace us with your presence and make the time for us again. It was an absolute pleasure. And of course, Dr. Mehta very ably chaired the whole session. And it could not have been possible without the participation from all the enthusiastic attendees today. It was really brilliant. Incidentally, the questionnaire that you did share with me last evening, Dr. Foote, I have already posted it on various forums. So most of the participants who are on the platform today may have already received that
Dissociative
questionnaire.
experiences scale. Great.
Yes, the scale. So, and any which way, we'll try and put it up on the website for people to be able to access at a later point in time. So, the whole purpose of knowledge is it has to be shared openly. Everything that we do is an open platform, and in perpetuity, all the lectures as well as the slides are accessible. For all the lectures that we have taken in the past, Dr. Foote has very graciously agreed to share his slides from today's talk on the website as well. So all of you will be able to revisit these slides and the entire talk in a video form on the website as well as our YouTube channel. So thank you all very much, and we are grateful for you to have taken the time again, Dr. Foote and Dr. Mehta. And I just would like to ask Chetan to just wind up the session today. Chetan,
To
over
say
to you.
thank you. It was a pleasure.
My pleasure, sir. Thank you.
Chetan, are you with us? I think there was a software glitch, so maybe some of us got logged on. But thank you all very much, and we promise to bring you such talks in the future as well. And we hope you will participate as enthusiastically as you did today. And of course, we thank Sun Pharma for their unflinching support, and we hope to be able to continue to inspire our postgraduate students to learn from this forum and from every platform that they can get good information access any knowledge from. So thank you all very much and wish you all a great evening ahead. Thank you.
Thank you.
Thank you.
Thank you.
Attention. A visitor has